Hi, everybody. Thank you for having me today. My name's Dr. Jodie Ouahed. I'm a pediatric gastroenterologist, and I'm very fortunate to be giving you this talk to the Immune Deficiency Foundation today. As my title states, I'll be talking about managing gastrointestinal issues and primary immunodeficiency. So just to give you a little outline of what we'll be talking about today, to begin, I'll start with providing a little bit of context and explaining why this topic is of high importance. Next, I'll display to you some of the symptoms that can signal an underlying gastrointestinal issue that merits investigation. I'll follow this by going over some of the common GI issues that we might see in primary immune deficiencies. I'll specifically touch on infectious diarrhea, food allergies, celiac disease, inflammatory bowel disease, or IBD, and autoimmune enteropathy. Next, I'll give an illustrative example of interest, highlighting chronic granulomatous disease, or CGD, and I'll end by letting you know where the field is going. So just to provide a bit of context, the gastrointestinal tract is filled with a large variety of immune cells, and these are very important to maintain healthy immune functions. It's also important to remember that the cells lining the intestine form the barrier between one's body and all of the food, the dirt, and the bacteria that is found inside our intestines. It's important to appreciate the role of the immune system in the GI tract, and in particular, patients with primary immune deficiencies are at an especially higher risk of developing gastrointestinal manifestations, with some reports being up to half of the patients. So some of the issues we commonly see that affect the GI tract in patients with primary immune deficiencies include diarrhea from an infectious source, food allergies, inflammatory bowel disease, celiac disease, and impaired absorption of nutrients and calories. And of course, it's really important to know what we are treating so that we can best help our patient and provide the safest and most effective management plan. So here is a list of GI manifestations that really merit a more comprehensive evaluation and likely a referral to a gastroenterologist. Symptoms on the left might be a little obvious to you. These include abdominal pain, nausea or vomiting, diarrhea that is with or without blood, and a big sign that is important is diarrhea that wakes you up at night. In adults, a loss of appetite or weight loss that is unintentional is also worth investigating. And in children, seeing either a plateau in their weight and height gain or a delayed onset in puberty would be other signs. To the right, you'll see some signs and symptoms that are less obviously related to the GI tract, but can certainly be related and merit a discussion. So these include fatigue or loss of energy or stamina, recurrent mouth sores like canker sores, certain kinds of skin rashes, painful or swollen or red joints, and intermittent fevers that are not related to a known infection. Let's start with one of the most common GI manifestations seen in patients with primary immune deficiencies. This is infectious diarrhea. So infectious diarrheas, or diarrhea from an infection, either bacteria, virus, or a fungus, tend to be more severe and last a longer duration than they would in an otherwise healthy person. They can also be caused by unusual infections that normally would not infect somebody with a healthy immune system. And like I mentioned before, these can be from bacteria, viruses, fungi, or even parasites. The treatment is typically needs escalation as compared to a healthy person. That is, these patients with primary immune deficiencies may need a more intense or a longer duration of an antibiotic or an antiviral agent in order to clear the infection. Sometimes we can try to prevent having these infectious diarrhea bouts by providing immunoglobulins in conditions where these are low, such as in CVID or combined variable immune deficiency. The next topic I wanted to share is that of celiac disease. On the left column, you'll see some GI symptoms that can happen when you have celiac disease. These are very variable. So some patients present with diarrhea, others with the total opposite of constipation. Some have weight loss, some have abdominal pain. Over the long term, if celiac disease is not treated properly, it can lead to intestinal cancers, which is why it's so important to identify and to treat it. Celiac disease can also lead to nutritional deficiencies, and ironically, some patients with celiac disease don't have any GI symptoms at all. In the middle column, you'll notice manifestations of celiac that happen outside the gastrointestinal tract. So these include iron deficiency anemia, failure to grow or being shorter than your genetic potential, a delayed puberty, being chronically fatigued, having weak bones, also known as osteoporosis in children or osteopenia in adults, fertility problems, problems with your tooth enamel, and skin rashes. And it's important to diagnose and manage this, like I said, because if it goes for a long time untreated, it does increase one's risk of intestinal cancer. The diagnosis is sometimes more challenged if a person has low immunoglobulin A or IgA, but it can still be done. And the main treatment for this as of now, although research in this field is growing exponentially, is to abide by a very strict gluten-free diet for the rest of your life. Next, I wanted to talk to you about inflammatory bowel disease, or IBD. The two main types of IBD include ulcerative colitis and Crohn's disease. We manage this with a whole variety of different immunomodulators, biologic agents, sometimes surgery, and sometimes even nutritional interventions. Inflammatory bowel disease tend to be fairly common in patients with primary immune deficiencies, and here are just a list of some. So we tend to see this in patients with XLA or X-linked agammaglobulinemia, in hyper IgM syndrome, in SCID or severe combined immune deficiency, in CGD or chronic granulomatous disease, in glycogen storage disease type 1b, mevalonate kinase deficiency, Wiskott-Aldrich syndrome, and NEMO. Let's talk about autoimmune enteropathy. There's two main kinds of autoimmune enteropathy. One is seen with something called IPEX syndrome, or immune polyglandular endocrinopathy that is X-linked. These patients typically present with profound diarrhea very early on in life. They often will have a variety of food allergies. They might have liver disease and type 1 diabetes. They often will develop a skin rash, and oftentimes other parts of their body have autoimmune disease affecting it as well. IPEX syndrome is very severe, and it tends to be life-threatening if not treated. Initially, IPEX syndrome is often treated with strong immune suppression, such as using agents like Tacrolimus, Sirolimus, and azathioprine. However, the main goal is to try to prevent long-term damage to the organs from autoimmune disease and providing a bone marrow transplant as long as a suitable donor is identified. Another condition that can lead to autoimmune enteropathy is CVID, or a combined variable immune deficiency. Some genetic examples that can lead to CVID are from mutations in a gene called CTLA4 and another in LRBA. Basically, both of these will result in an autoimmune condition that can affect the liver, it can attack the bone marrow, it can also result in type 1 diabetes, can result in thyroid and lung disease, and of course result in an autoimmune enteropathy. Since we've learned more and more about these genetic causes of CVID, we've been able to better tailor our treatment and use a medication called Abatacent that directly addresses the impairment in the genetic pathway to address the CVID and all of the associated autoimmune symptoms. Next, I wanted to talk about CGD, or chronic granulomatous disease. Patients with CGD have an impaired ability to kill bacteria and fungi. Most patients present when they're children, usually when they're younger than 5 years old, and they often will come with recurrent severe infections involving the lungs, the skin, and their bones. And about 32 to 48% of patients will develop notable gastrointestinal manifestations. These can vary, of course. Some are infectious diarrhea, like we discussed before, Crohn's disease involving fistulas, which are abnormal connections between the intestinal tracts or the intestine and other body parts like the skin. Patients with CGD can also have gastric outlet obstruction, or that is a narrowing distal or beyond the stomach that results in an obstruction and vomiting. Patients with CGD can often have mouth sores. They often have abnormal motility or movement of their esophagus and stomach. They can have narrowing in their gastrointestinal tract. They can develop abscesses in the liver, just like they can in their lungs, skin, and bones. And typically, these patients have difficulty growing and gaining weight and height. The management of CGD is a little unclear. It's not very well defined. However, people tend to use antibiotics and interferon-gamma to help prevent infections in these patients. Sometimes when there's narrowed areas of the GI tract, we use surgeries to cut those narrowed areas out. It's important to identify if you have CGD and you're managing GI manifestations, because anti-TNF agents, which are strong immune suppressing agents, should really only be used with extreme caution, because there have been several cases of fatal infections when patients are on these kinds of medications. The good news about CGD is that similar to treating patients with IPEX syndrome, a bone marrow transplant is curative. And people are currently investigating novel ways to use gene therapy to cure this disease. So to conclude, I wanted to share, where is this field going? The good news is that we are developing a much greater understanding of the role of genetics and specific primary immune deficiencies and the GI disorders that develop as a result of them. This has been very beneficial to us as it has enabled a much tailored therapeutic and curative approaches. It has enabled us to refurbish medications for new purposes so that we can address the GI manifestations of primary immune deficiencies. So while there are a lot of GI manifestations seen in patients with primary immune deficiencies, the good news is that the future is really bright. It holds a lot of promise in better understanding and personalizing medicine so that we can better use our understanding of genetics to better address the pathways that are affected and treat the disease. Thank you so much for having me. I hope you enjoy the rest of your day.
Good afternoon, everybody. Before we begin the Q&A, please remember that each individual's treatment and condition is unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified health provider with questions concerning a medical condition. At this time, please join me in thanking Dr. Jodie Ouahed from Harvard Medical School and Boston Children's Hospital for that wonderful presentation, and saying welcome to the Q&A portion of this session. So we have received a lot of terrific questions, and we will try to get to them as many as possible in the time we have. So we're going to start with, is constipation and loss of peristalsis, including gastroparesis, related to PID?
Thank you. Thank you for that introduction, and thank you everyone for these engaging questions. So as to the first question about constipation and loss of peristalsis, such as gastroparesis being related to primary immune deficiency, I think it's more dependent on the underlying subtype of primary immune deficiency. So for instance, in my presentation, I explained how you can have lack of motility with, for instance, CGD or chronic granulomatous disease. So in that subset of patients, upper tract peristalsis and dysmotility has been well described. For others, for instance, let's say, I discussed CVID secondary to CTLA4 or LRBA deficiency. To my knowledge, constipation is not a feature of that kind of primary immune deficiency. So at the end of the day, I think it depends on the subtype and obviously what other underlying disorder one might have, such as, for instance, underlying celiac disease or other underlying GI disorders.
Thank you. I have CVID and often get very sore mouth cankers. accompanied by flu-like symptoms and fatigue. The cankers and flu-like symptoms take up to 10 days to clear up. It seems to come and go in flares and appears to be triggered by certain foods, but not necessarily acidic foods. What kinds of gastrointestinal issues could cause this, and how can I prevent this?
This is a great question. Canker sores that last a long time can sometimes be seen in underlying Crohn's disease because, as you know, Crohn's affects anywhere from the mouth, the lips, all the way down to the rectum. And one of the main features of it are aphthous ulcers or canker sores in the mouth. Having said that, there is a subtype of Crohn's disease called orofacial chromatosis or orofacial Crohn's disease. And it's interesting you talk about dietary interventions because there's evidence that avoiding preservatives, cinnamon, benzoate, or benzoic acid can help with minimizing some of the aphthous ulceration seen in this disease. The only other main thing that comes to mind with frequent canker sores would be like an underlying like dermatomyositis that is sometimes seen with other conditions, but I would say Crohn's is the biggest one that I would be worried about.
Thank you. Is it more common for PID patients to have pancreatic insufficiency?
Great question. Again, I think it depends on the subtype of underlying primary immune deficiency. So again, for instance, from the PowerPoint I discussed CVID secondary to LRBA or CTLA4 deficiency. In those patients, yes, we have seen pancreatic insufficiency. In other types of primary immune deficiencies, to my knowledge, at least, that is not something that's well described. So it depends on the cause.
Is it more common for PID is delayed gastric emptying motility tied to primary immunity, and how can it be treated?
So I think I answered that tangentially with the first question about dysmotility and primary immune deficiency. So again, I think it depends on which one you are treating, or which primary immune deficiency you have. As I was saying, CGD or chronic granulomatous disease, that is well characterized in that subtype, but not in others. How it's treated really depends on where the dysmotility is. I am not a motility expert, but I do know that we have a variety of different agents to help with either upper tract problems, like if the dysmotility is in the food exiting the stomach and going into the first part of the small intestine, or in moving along the small intestine or moving along the colon. There are different motility agents, different things that, for instance, we have agents that can help relax the stomach, like periactin. We have things that can help move things along in the small intestine, like erythromycin. And then we have a variety of colonic stimulation agents. Another means of fixing this, especially if it's upper tract, is some people inject Botox to the pyloric sphincter, which is that muscle that basically is the barrier between the stomach exiting into the small intestine, to help relax that, to help pass food through. So it really depends what the underlying problem is and where it is, so that we can best address the motility issue.
Perfect. I am constantly hearing about diarrhea as a symptom of GI issues in PI. I have chronic constipation. Can this be caused by a PI other than celiac disease, and this person has CVID?
Yeah, I'd be curious to know which type of CVID the patient has, because the main one that I know of, like I said, is CGD. I'm not well aware of other types of CVID that typically result in constipation. I apologize. I don't have more specific answer for that.
Should patients with PI take any special precautions before undergoing a colonoscopy, and how often should a colonoscopy be performed?
That's a great question. So in terms of special precautions, I think it depends on how severe one's primary immune deficiency is. As long as their neutrophil count, which are the types of cells that typically fight new infections, we do not, as long as the neutrophil count is within the normal range, we do not typically make any special precautions. Of course, usual precautions is, should you develop a fever or any significant symptoms within the 24 hours of having a colonoscopy, it's imperative that you call the doctor and let them know, and you will most likely need to be evaluated. Having said that, as long as the neutrophil count in the underlying patient is within normal range, usually we do not take specific measures, but of course, every patient is unique and there are exceptions to that rule. With respect to the second part of your question of how often a colonoscopy should be performed, I think this is based primarily on in addition to the regular routine, cancer screening and the like for colonoscopy for adults, the main driver of how often a colonoscopy should be done should really be based on one's clinical symptoms, and if there's any concern of an underlying pathology or disease in the GI tract that merits colonoscopic investigation. So, for instance, if you have underlying CVID or other primary immune deficiency and you're diagnosed with Crohn's, it's important that you get regularly scoped, at a minimum every couple of years or so to make sure that your disease is under good control and that you don't have any signs of precancerous changes. However, if you have another primary immune deficiency and you do not have a specific underlying GI disorder and your clinical symptoms are such that you do not have notable diarrhea, weight loss, your nutrient levels checked in your blood are appropriate, and there's no significant concern, I would not recommend any additional colonoscopy in addition to the regular routine screening that we do for adults in general.
Thank you. I have a couple questions here on enteropathy. How common is it to find autoimmune enteropathy in CVID patients? Do you need genetic testing to diagnose I think they mean CVID enteropathy.
Yeah, I assumed that that was the same from reading that question. I apologize if we're misinterpreting it. So I actually don't know the specific number of, fraction of autoimmune enteropathy with CVID. I will say it's not uncommon. It is something that is constantly, on my mind as a possible explanation for one's diarrhea or loose stools or GI complaints, weight loss, what have you, with underlying CVID, but I don't have a specific number in mind. I think it also depends on, underlying severity of it. No, you do not necessarily need a genetic test to define this. Evaluation can be completed by, a thorough exam, physical exam and history, followed by a scope with biopsies to confirm the autoimmune nature of the enteropathy. Sometimes in addition to that, we will test for certain kinds of antibodies, but this is not a critical part. But genetics is not critical for a specific diagnosis of autoimmune enteropathy. That would be more to better understand the underpinnings of the underlying primary immune deficiency.
Thank you. Can you take too much Imodium? Is there a long-term effect from taking it too often?
You can always overdose on any medication. I actually don't know. I don't prescribe Imodium all that often. Hold on one second. I can probably look this up pretty quickly. I don't know. It's not very clear to me from quickly looking this up. I honestly don't know, but I do know that you can always overdose on any medication, so I would not recommend overdoing it with Imodium. And then another consideration with Imodium among patients with primary immune deficiency is that, patients with primary immune deficiency are obviously at higher risk of having an underlying infection. And taking Imodium, if you have an infection, is a very bad idea because your body is trying to excrete the bacteria, the virus, or the parasite that was ingested. And if you take Imodium, you're actively inhibiting the body from doing that. So you can get pretty sick from an infection if you take Imodium in context of an infection.
How common is small intestinal bacterial overgrowth with those with primary immune deficiencies? How would this be treated properly with antibiotics while avoiding C. difficile?
That's a great question. SIBO or small intestinal bacterial overgrowth can certainly be seen in patients with CVID. I don't know that it's that much higher than in the average population, but there's a whole variety of risk factors for developing small intestinal bacterial overgrowth, including anatomic factors, having CVID, having like a lot of constipation or stasis, things not moving through. And I would say the best way to manage it while trying to balance not having C. diff is to try to take a probiotic at the same time of taking an antibiotic for C. diff to help prevent that. So one of the rare instances where a probiotic has actually been found to be clinically helpful is in preventing recurrence of C. diff, and the specific probiotic to take is called S. boulardii. It can be found over the counter as Floristor. So I would recommend taking that during and after the course of the antibiotic to help prevent C. diff. Great question.
Thank you. Is chronic gastritis and duodenitis associated with CVID and or other PIs?
Yeah, so chronic gastritis is something that we see almost all the time. It's very rare that I get a biopsy back and you don't see chronic gastritis. I think that is just exceptionally common in otherwise healthy people without an underlying primary immune deficiency, and equally common in patients with primary immune deficiency. Chronic duodenitis, however, would be a little bit different. And yes, that would be just like underlying Crohn's and other like autoimmune enteropathy are more common in patients with CVID and primary immune deficiency. So is chronic duodenitis.
How do bile acid sequestrants such as cholestyramine work in PI GI diarrhea?
So bile acid sequestrants, as the name implies, basically like adsorbs and binds the bile acids and in so doing, that mechanism in and of itself helps prevent the diarrhea. So by sequestering the bile acids, the diarrhea in some people, depending on the type of diarrhea they have, would improve. But this doesn't work for everyone. It depends on the type of diarrhea.
Is IBS common in PI, or is it usually misdiagnosed IBD?
So I wonder if your question, if you mean to ask, is IBD common in PI, or is it usually misdiagnosed as IBS? Let me explain myself. So IBD is inflammatory bowel disease, for which people have true signs of very clear chronic inflammation when we look at the biopsies under the microscope following a scope. IBS, however, is more of a diagnosis of exclusion, and it follows a variety of clinical criteria that people have. And there's a wide gamut of different types of IBS. You can have a constipation type, a diarrhea type, or a mixed type. And so it's quite uncommon to misdiagnose IBD just because the findings are there. You see them under the microscope, unlike IBS, where it's more of a clinical history that you take. So I can see how people might have underlying IBD and not proceed with a scope and then falsely assume that the patient has IBS. But I don't think that after one gets a scope and sees the chronic changes of IBD, one would say, oh, this must be IBS, because that would just be very contrary. I hope that made sense.
Is achalasia 3 common with CVID patients?
That's an excellent question. You've stumped me. I have never heard of achalasia being associated with CVID. That's not to say that it can't happen, but I don't know about it to my knowledge. So my guess is that it would be quite rare.
I've been tested for celiac disease, both biopsied, blood tested, and tested negative. However, I was avoiding gluten when tested, so maybe the test was not accurate. I feel better staying gluten-free. Are the tests accurate for CVID patients?
That is an excellent question. I actually struggle with this as a physician because it's less straightforward. So patients with CVID you are right in saying that there's a blood test, which is really a screening test, which works for about 97% or so of the population, assuming that you have adequate numbers of IgA and IgG. Now, that might not be the case for patients with CVID, and patients might be taking, subcutaneous or IV immunoglobulins that aren't theirs. So the main way through the blood that we test for celiac disease is less reliable in this population. Having said that, the biopsies are the golden standard. They are the best test that we have. Unfortunately, celiac disease can be present in a patchy fashion. So you can have, for instance, on this part of your intestine, evidence of celiac, and then normal, and then celiac again, and you could just be unfortunate enough to biopsy the very healthy area and miss it. That is quite rare, but it is reported in the past. So while the blood test is less reliable, the biopsies are usually very reliable, with that tiny exception of the patchy disease. About feeling better while on a gluten-free diet, I'm glad you found something that helps you feel better, but there is another entity that you should keep in mind, and that is gluten sensitivity. Some people do not have celiac disease, but they have a variety of symptoms. They feel foggy-headed, they feel bloated, they feel uncomfortable, they have pain within hours of having gluten. So some people respond to that. And lastly, you did say that you were avoiding gluten around the time of the scope, so that can certainly give you false negative biopsies. That is, it's very important to eat at least a small amount, the equivalent of one slice of bread, for at least the 4 weeks before having a scope, in order to be confident that the biopsies will reveal celiac disease if you have it.
Interesting. Have you seen a benefit of fecal transplant to help correct microbiome imbalance from PI?
So I'm a pediatric gastroenterologist. We have very few indications for doing fecal transplants, and changing the microbiome is certainly not one of them, especially in patients with PI. I do not know, I would imagine that this might be more of a practice, if at all, in adults, but I am not aware of this. I apologize. Not in children.
I have a very rare PID, and I'm having GI issues since I got the first mRNA COVID shot almost 12 weeks ago. Are you seeing this in others with PID? If so, how long before it goes back to normal?
So GI issues, specifically diarrhea, has been reported in patients who got the COVID shot, not in an alarmingly higher rate than in patients who got placebo, but still higher. I will say that I have had some patients with underlying inflammatory bowel disease who have had exacerbation of their GI disease following the COVID vaccine. I do not know what the timeline of getting back to normal is. So I do think that there's a subset of people who have, a predisposition to have a GI symptoms being triggered following further stress on their immune system, and especially if they have primary immune deficiency. The timeline to improve, I think this is uncharted territory. The COVID vaccine is new. This is new territory. I'm sorry, I don't have an answer.
How about recommendations for treatment of small bowel bacterial overgrowth syndrome due to a total absence of IgA?
Yeah, that's a good question. So I think I would initially treat small bowel bacterial overgrowth the same way. So me as a gastroenterologist, the main way that I treat that is by giving a course of antibiotics. Let it be rifaximin or Flagyl. Those are the two my main two go-tos. And then I would be working closely with an immunologist to address, the low IgA and whether any intervention should be performed for that. But I would initially approach it just like I would all of my other patients, by starting off with antibiotics and seeing how they do. There are some people who are particularly predisposed for having small intestinal bacterial overgrowth, and for them, sometimes I will give them cycles of antibiotics to help prevent it. So, you know, for instance, you go on one antibiotic 1 week, you wait 4 weeks, you go on a different antibiotic, then you wait another 4 to 6 weeks, and then you go again. So cycling antibiotics is sometimes an intervention that that is used in patients who are exceptionally susceptible to it. But I would first, of course, check in with the immunologist in case there's something that they can do on their end to help.
How do you know if you are not properly absorbing nutrients and iron as opposed to just not getting enough in your diet?
Well, I guess primarily through the history and through the blood work. So, you know, it's important to have like the proper amount of iron in the diet. And I don't know if the person in question is vegan or vegetarian, but the first step would be establishing how much they are taking and whether or not it's an adequate amount. If they're not taking the adequate amount, then that would be the first thing to fix. If they are taking the adequate amount, then the question really goes as to, like you said, are they not absorbing it? So if one is iron deficient, you'd want to see why. One main reason from that could be because one is bleeding from somewhere. As a gastroenterologist, I think about the GI tract. So sometimes people would be bleeding from their GI tract and not necessarily seeing blood with the eyes because the amount of blood is microscopic. So that would be like the first way of trying to tease out what is going on. I will just add that in the context of intestinal inflammation, often people cannot absorb iron taken by mouth. Like even if you were to take, for instance, iron supplements in context of fulminant colitis or inflammation of your colon or small intestine, one often will not be able to absorb that. So in patients who are taking enough, either by mouth, through their foods, or through supplements, in some contexts where the intestine is very inflamed, you need to actually provide it through intravenous method.
Do you have any suggestions for managing recurring SIBO? How do patients with immunoglobulin deficiencies move past SIBO permanently after taking the appropriate course of antibiotics and having it come back?
Yeah, I'm sorry to hear that. I think at that point, my recommendation would be doing what I said, I think a couple of questions ago about cycling your antibiotics.
Is there any cure for Pseudomonas aeruginosus?
I am looking this up right now. Let me see if I can get you a quick answer. I am not aware of this. So yes, there are different antibiotics that people use for this, usually 2 antibiotics at a time, apparently. I don't believe that I've ever treated this bug to date, but there are combinations of antibiotics that people recommend for this, specifically Cipro and Tobra.
Thank you. I tested low in VC once, and then it came back normal in a few weeks. Should I do anything, and if so, what?
I'm not sure what VC is.
Yeah,
I'm sorry.
Maybe they can ask. Do PI patients who also have connective tissue disorders like Ehlers-Danlos syndrome frequently suffer from GI disorders, and what can they do for chronic constipation?
That's a great question. Yes. Oh, sorry. Hold on. I think I misunderstood the question. Give me 1 second. Do PI patients who also have connective tissue disorders? Yes. So the connective tissue disorders like Ehlers-Danlos, like you gave an example of, have been shown to have a variety of GI disorders, primarily of like hypersensitivity and pain and sometimes motility problems. You know, at a higher frequency than the average otherwise healthy population. And, you know, the interventions to manage chronic constipation would be the same that I would say for other patients. You know, we have laxatives, we have stimulants, we have osmotic agents, and of course there's behavioral therapies.
Could taking antiviral, antibiotics, and lots of supplements for a few years affect the GI tract, for example, absorption of nutrients?
So taking a lot of antivirals and antibiotics will obviously perturb your microbiome, or the healthy bacteria and bugs living in your GI tract. And so taking this regularly could increase your like susceptibility to getting infection, which would be my main concern. In terms of specific GI issues like affecting absorption and nutrients, I do not know of a mechanism where antibiotics does that. There are some conditions where I recommend antibiotics for like 3 to 4 months on end, because some antibiotics actually have anti-inflammatory properties in the GI tract, which can be helpful for treating some diseases. Having said that, we generally do not recommend long-term antibiotics or because of the antibiotic resistance concern. So I don't have any evidence to say that this would eventually in the long term affect absorption of nutrients, because nobody really knows, because nobody really does that. But taking them for a few months at least does not seem to have any issue with the GI tract absorption.
Can patients with CGD actually have Crohn's disease, or only Crohn's-like symptoms? Does Crohn's require different treatment versus only having Crohn's-like symptoms?
So this is a great question. I think this is like a language minutia that some people might interpret differently than I. So I consider patients who have Crohn's or Crohn's-like disease with underlying CGD to actually have Crohn's disease. I don't call it a Crohn's-like symptom, because typically, like, in the patients that I have with CGD who have Crohn's, when I look under the microscope and I look at the biopsies, I do see all of the characteristics that I see with Crohn's. I think the reason why sometimes some physicians refer to this as Crohn's-like symptoms is because they feel that the underlying diagnosis is CGD, and so they many times people don't want to give too many different diagnoses, especially if there's one underlying thing. So I think what's a little different with a Crohn's secondary to CGD is that CGD is the genetic and the immune driver of the Crohn's, but it is Crohn's. And in terms of treatment, so patients with CGD, there have been reports of having fatal infections when they're on an anti-TNF agent. And so for that, anti-TNF, such as like Remicade and Humira. So for that reason, oftentimes we like to avoid such agents to manage the Crohn's.
We are almost out of time, but if it's okay with you, we'll continue with just a few more questions, because I think we can go a little over without them stopping it.
Okay.
So the next question, could taking antivirals, antibiotics, I have CVID and don't absorb certain vitamins or fat well. Why does this happen, and can something be done to fix this?
That's very interesting. I'd be curious if you were scoped already, because I wonder if you have like an autoimmune enteropathy or intestinal inflammation of some sort that is impairing your absorption. So depending on what your underlying GI part of the pathology is, potentially something might be able to be done. Sometimes it's a matter of getting the inflammation under control. Other times it's a matter of trying to overcome it by giving additional supplements, so that if you're only absorbing, let's say 30% of what you take in, and you just overshoot so that you get the right amount finally absorbed.
How do you determine if you have a malabsorption issue?
Great question. So clinically, symptoms people typically have is diarrhea. Sometimes people will see droplets of oil on the toilet bowl after they have a bowel movement, kind of like floating on the top of the water. But there can be a variety of different types of malabsorption. So stool tests would be the underlying ultimate way to tell. We can take your stool and look for reducing substances or carbohydrates. fats, and proteins. And if we see that, then we know that you're malabsorbing it. If we see that at a too higher concentration than is expected, then we know you're malabsorbing.
What do you think of the daily use of protonics on a long-term basis?
That's a good question. So there's a lot there's a lot of literature and newer literature on this. Of course, there were prior papers out saying about a whole variety of side effects with long-term protonics. So I feel that it's always a risk versus benefits ratio. If somebody needs protonics, I definitely don't hesitate to give it for a short term. So by short term, I mean a few months, and then I always try to gradually wean someone off of it. And if that doesn't work, of course, I am more concerned about the long-term side effects of protonics. And so if I'm unable to wean someone off of it within a few months, I will try to at least at minimum try to reduce the dose that they are on to try to prevent some of the long-term side effects. So it's like I said, risks versus benefits, quality of life, versus unpleasant life. But I try to minimize it as best as possible while balancing, feeling okay.
Can a teenage child with IgA and polysaccharide antibody deficiency develop autoimmune gastritis? She has had SBIO in the past. As her mother, I have the same PI and was diagnosed with autoimmune gastritis and parietal cell AB presenting with B12 deficiency. My gastric BX was negative. I asked her PID GI and was told the child would have to have a positive BX for diagnosis.
I'm just wrapping my head around the question. Give me a second. So anyone can develop an autoimmune gastritis, and so parietal cell and AB antibodies are, and B12 deficiency would make me very, very suspicious that somebody is having autoimmune gastritis. Like that comes hand in hand. So I'm a little confused at the end of your question. Your gastric biopsy was negative, and that you'd have to check the child to see if the positive biopsy. So yes, I think ultimately you do want biopsy confirmation of an autoimmune gastritis. However, the presentation that you're showing with the parietal cell antibody and B12 deficiency, that the parietal cell antibodies, I'm assuming that that's from the biopsy. That in and of itself would be a positive diagnosis. So I guess I'm a little confused as to what you mean, because it sounds like you've made the diagnosis from your question. But basically, the patient needs a scope, needs to confirm that there's the antibodies, as you said, and then the diagnosis can be closed.
Can you speak briefly about post-infectious colonic motility disorders, especially after severe infectious gastroenteritis?
Sure. So post-infectious colonic motility disorders, so I guess the medical term that I typically use for that is post-viral gastroparesis, but that's more like stomach ones. But you can also have, after a virus, infects, you can often have a variety of gastrointestinal complaints and disorders. And the underlying mechanism that we think probably happened is that it's probably like a oversensitization of one's nerves following the irritation from the virus that either makes your transit faster, makes you feel full, makes you feel bloated, makes you feel not well. In pediatric patients, we usually support patients symptomatically, sometimes provide also some biopsychosocial approach to help cope, and try to avoid any triggers that causes any symptoms. And most patients do well over time. However, over time is variable. Some people improve in a matter of months. Some people improve in a matter of, it takes them about a year or so. But post-infectious GI disorders are not uncommon.
Could something like lymphangiectasia Granulomatous, be common with patients who have primary immune deficiency? I was diagnosed based on an EGD, but given no further information. Doctor said it was not her area of expertise. Who would I ask?
It's a good question. For your first question, I'm not aware of any association with lymphangiectasia and primary immune deficiency per se. So lymphangiectasia is sometimes seen on a scope because of basically like we see these white little specks that are accumulation of like fat in the lymph. I'm sorry you got no further information. I think I don't know who would be a good person to ask about this. I think I would probably more go towards what your symptoms were for which you were scoped to better understand what next steps you need to take, like what your symptoms were. You could certainly always ask for a second opinion from a gastroenterologist, but lymphangiectasia isn't something that I also typically see. Let me see if I can do. Give me 1 second. Yeah, I'm not sure who like owns that. It's like swelling of lymphatics. I do know that at Boston Children's Hospital, we do have a team that deals with lymphatic disorders, but that is a very, very specialized thing that might not be necessary for what your symptoms are. So I would really base, pursuing what's going on based on your symptoms.
Thank you. I've had an RNY gastric bypass long before my CDID diagnosis. Have you seen changes to immunity after RNY?
So I apologize. I'm a pediatric gastroenterologist, and the number of gastric bypasses that we do in kids is very, very, very slim. So I have not seen, any changes in immune. I'm not aware of any. But then again, my the number of patients that I've seen with this is exceptionally small. So I don't think I'm the right person to ask. I apologize.
Could yeast in food contribute to GI problems?
So yeast in food, like a full-on infection, if you were to eat something that was old and moldy, sure, of course you can get an infection, especially if you have a primary immune deficiency. For like regular yeast, like eating, bread that has, risen, no, it should not.
And I think this will be our last question. Can you speak about post-infectious enteropathy?
Sure. So post-infectious enteropathy, sometimes you have more diarrhea following an infection. This is often secondary to a secondary lactose insufficiency. So your small intestine basically has a bunch of villi or like finger-like projections, and the lactase enzyme is typically on the very tip of it. And when you have diarrhea, you kind of like wash that all off. So that can sometimes take, a couple of weeks or so to improve. But usually it gets better with time. And avoiding lactose for the first couple of weeks is probably a good idea.
Well, thank you so very much for allowing us to go over and answer additional questions. But our time has come to an end. So we want to thank you, Dr. Ouahed, very, very much for your time today. It's been an honor to have you join us, and everybody else joining us. We appreciate the time that you've taken to be here. I hope that you all enjoy the rest of the conference, and I hope to see you in person again someday. Everybody take care, and thank you. Bye.
Thank you so much for having me. Bye.